Good morning, all. Thank you for attending today's education session. Recently, through speaking with some of you on road and conducting some case reviews and reviewing case sheets, we've noticed a paucity of knowledge around the assessment, identification, and management of seizure patients. Whilst we appreciate that seizures present in a wide range of different ways, and there are many different causes of seizures, today we will focus solely on the adult convulsive status epilepticus patient. Today we're going to cover the following topics: pathophysiology, clinical features, physical examination, pharmacology and management, some relevant investigations, decisions regarding transport, and the leadership roles required. Due to our limited time, please note any questions you may have and hold them to the end. Today we will pay particular attention on the intensive care paramedic treatment of these patients. Whilst the basics, which we will briefly cover, are always important in managing these patients, we as ICPs have additional skills in pharmacology that benefit these patients and provides the best potential outcome for these patients. Let's have a review of some pathophysiology. Status epilepticus is known to be a disease process that presents with high levels of morbidity and death. Traditionally, status epilepticus was defined as seizure activity lasting 30 minutes or more without a return to normal conscious state between seizures. However, in 2012, the United States Neurocritical Care Society changed the definition of status epilepticus to continuous clinical and/or electrographic seizure activity or recurrent seizure activity without recovery between seizures. The term status epilepticus may refer to all kinds of seizures, such as non-convulsive, convulsive, which we're covering, myoclonic, or focal. The convulsive status epilepticus is defined as generalized tonic-clonic movement and impaired mental status. Within the brain, there is a large interconnected complex networks of neurons. Each of these neurons are linked to hundreds of other neurons. These are connected via synapses. These neurons discharge or depolarize electrical current, and neurotransmitters are released at the synaptic levels, and these allow for intercommunication through the neurons. In normal brain function, neurons discharge regularly and at low frequency. However, as a result of several different mechanisms, such as head injury, drug overdose, or metabolic abnormalities, these neurons discharge at irregular high frequencies. Most commonly, the abnormalities of ion channels such as potassium, sodium, or calcium are what cause the seizure activity. Simple neurons regularly discharge abnormally, which is generally insignificant. However, when a large group of these neurons discharge at the same time in an irregular way, this is when seizure activity is triggered. During the large depolarization of these neurons, a train of action potential is fired. This is known as paroxysmal depolarizing shift. In partial seizures, this is usually contained to the area of the brain it originated from. However, during seizure activity, this spreads due to the failing of inhibitory neurotransmitters. However, in generalized seizures, the increased activity is widespread throughout the brain simultaneously. The true cause of this increased activity from multiple areas of the brain is not completely known. However, it is hypothesized that it may be from hyperexcitability of neurons through the cortex of the brain and abnormalities in neural networks that connect the cortex to the thalamus. Let's review the neurotransmitters involved, these being glutamate, aspartate, and gamma-aminobutyric acid, or GABA for short. Glutamate is an excitatory neurotransmitter, and GABA is an inhibitory neurotransmitter. GABA acts on the ion channels and increases the release of chloride and decreases the formation of action potential. Glutamate, along with aspartate and acetylcholine, allow for the influx of sodium and calcium, which allows for the formation of action potential. Understanding this underlying pathophysiology and the neurotransmitters involved in status epilepticus guides us as paramedics to provide clinically appropriate care to patients presenting in this condition. Let's have a review of the clinical features and the physical examinations required. As we discussed, these patients will present with convulsions, generalized tonic-clonic movements of the extremities. The tonic phase is when muscles stiffen. This means a conscious patient will fall to the floor. Also to note, the vocal cords will stiffen, and this will cause a groaning or cry sound as air passes these vocal cords. After this tonic phase, the clonic phase occurs. This is where the limbs jerk rapidly and rhythmically, and there is continuous bending and relaxation at the joints of the elbows, hips, and knees. The patient, while seizing in convulsive status epilepticus, will present with altered conscious states. They will not respond to verbal or painful stimulus. During this period, respiratory compromise will present. Therefore, these patients will appear hypoxic with cyanosis present. These seizures, as discussed, will last for over 5 minutes, or these patients will not recover in between these seizures. So a patient may have seizures lasting 1 minute, but they won't recover between their next seizure, which may also last for 1 minute. But if this continues for over 5 minutes, that's status epilepticus. Due to our work, when being called to a patient who is seizing, we need to remember the timeline of the case. If someone calls for a patient who is seizing, we need to take into account the time of the call, our response time, how long it takes us to get to the patient. If the patient is still seizing on our arrival, we should really suspect and strongly consider status epilepticus. Due to the abnormal firing of neurons and loss of muscle control, urinary and fecal incontinence is common in these patients. This particular symptom can be useful in identifying status epilepticus over other forms of seizures. Taking a vital sign assessment comprising of SpO2, blood pressure, and electrocardiogram will be near impossible with the constant violent convulsing of the patient. Therefore, pre-hospital diagnosis of the status epilepticus patient will depend on the identification of clinical features. Whilst the physical examination of the seizure patient is used to identify the clinical features found, there are other things to identify in these patients. A physical examination should be conducted whilst managing these patients to identify any injuries that the patient may have sustained during the seizure. Nguyen and Zentino in 2009 identified that along with common bruises and abrasions, fractures and dislocations are highly prevalent in patients who have seizures. These injuries need to be identified and managed along with the management of the seizure. A physical examination should also be conducted to identify any potential cause of the status epilepticus. Things to be on the lookout include any potential identifiers of head injury, such as boggy masses or blown pupils. Assessing pupillary response in these patients can yield different results. Fernandez-Tor et al. In 2018 stated that these patients may present with something called pupillary hippus. This pupillary hippus is spontaneous bilateral synchronous rhythmic constriction and then dilation of the pupils. Fernandez-Tor et al. 2019 state this finding is more common in patients with underlying head injuries. Shirozu et al. In 2019 state that more commonly, patients in seizures and status epilepticus will present with pupil dilation and nystagmus. A full neurological examination in the actively seizing patient is going to prove pretty hard. Therefore, once the seizure is managed, a neurological examination should be conducted. This should include a GCS, coordination exam, cranial nerve exam, reflexes, and motor function. However, in a heavily managed patient, this is going to prove pretty difficult and may not change our treatment. Therefore, probably should be left off for the hospital staff to conduct. So how are we going to treat these patients? Early and aggressive management of these patients is important. This is important as it limits seizure-induced neuronal injury. And these neuronal injuries have been identified in animal studies and can be extrapolated to humans. And it has actually been shown to have better patient outcomes in humans. Firstly, we'll start with the basics. Oxygen therapy should be started to treat the hypoxia and respiratory compromise. 15 litres a minute via a non-rebreather mask should be placed on the patient. This will also ensure the large amounts of oxygen used by the brain while seizing is supplied and replaced. The first line agent to treat the seizure is midazolam. The advanced care paramedic treatment involves intramuscular midazolam, so we need to remember this may be given before we give further doses. The first dose of midazolam is given intramuscularly at a dose of 100 mics per kilo and can be repeated one time. So let's try the basics first before we go into the advanced stuff. If this does not work, further doses of 100 mic per kilo intravenous midazolam should be attempted. There isn't a maximum dosage for this. However, other agents should be considered when reaching the 15 to 20 milligram range, as the effectiveness of midazolam will decrease at this point. And this is due to the decreasing number of GABA receptors on which midazolam works on. If after 10 minutes of treatment seizure activity continues, a second line agent needs to be used. Keppra is what we will use. This is given at a dose of 60 milligrams per kilo via IV infusion over 5 to 10 minutes. Keppra is used over other second line agents such as sodium valproate as it is proven to be safest in pregnancy. If the status epilepticus continues after first and second line treatment, this is considered refractory status epilepticus. At this point, management of the patient requires rapid sequence intubation with an appropriately sized endotracheal tube. Recent research suggests that early intubation improves patient outcomes. The choice of induction agent and paralytic needs to be carefully considered. Ketamine should be used as the induction agent with a dosage of 1 milligram per kilo IV. Further dosing of 1 milligram per kilo at 1 to 5 minute intervals should be administered to maintain sedation post RSI. As ketamine blocks NMDA receptors, this is theorized as should be effective as NMDA receptors increase as status epilepticus evolves. However, there is a lack of evidence and research surrounding this. Suxamethonium and rocuronium both have their benefits and downfalls. Suxamethonium is a depolarizing blocking agent, which in some cases has been proven to worsen hyperkalemia in patients with status epilepticus due to their increased risk of rhabdomyolysis. Rocuronium, although preferred in this patient subgroup, has been demonstrated to be highly effective in cessation of the physical manifestations of the seizure. However, doesn't treat the seizure activity within the brain. Hyperkalemia secondary to rhabdomyolysis takes approximately 20 minutes to develop. For the patient who has had treatment started early, within the 20-minute timeline, suxamethonium should be used as the paralytic for RSI. Unless there are other concerns for hyperkalemia, suxamethonium should be administered IV at 1.5 milligrams per kilo as a single dose only. However, if the patient's been seizing for a longer time or you're not sure how long the patient's been seizing for, rocuronium should be used. Rocuronium should be administered intravenously at 1.2 milligrams per kilo, with further dosing of 0.5 milligrams per kilo. This is to maintain paralysis if required. Ketamine-only intubation is also an appropriate management plan if there are concerns regarding both choices of paralytic. In this case, ketamine IV needs to be administered at 2 milligrams per kilo, with further dosing of 1 milligram per kilo to maintain sedation. After the RSI, these patients need to be ventilated appropriately. These patients need to be ventilated to maintain normocapnia with end-tidal CO2 titrated to 35 to 45 milligrams of mercury. Kang et al. In 2017 found that patients hyperventilated post-status epilepticus who were hypercapnic had worse outcomes and higher mortality. Relevant investigations. Further investigation of these patients is limited pre-hospitally. If available, an ISTAT VBG machine may be useful in determining electrolyte imbalances. If any abnormalities are detected, it might not be fixable in the pre-hospital setting, but should be handed over to the hospital staff, which can allow for earlier management of this. A temperature should always be checked in these patients. Hypothermia is known to be a very common systemic response to status epilepticus, which may result in an increased risk of brain injury. And this increased temperature is due to the continual clonic movement during the seizures. Early treatment of this is vital. Removing clothing whilst maintaining dignity or utilizing the vehicle's aircon can be used to treat this. Again, a blood glucose should always be taken in these patients and should be conducted early. It is well known and documented that seizure activity results in impaired glucose metabolism. Therefore, any presentation of hypoglycemia with these patients should be managed concurrently, as this may be a simple cause of the status epilepticus. Let's have a look at these topics now. The patient, once managed and stabilized, requires urgent transport to hospital for further assessment and management. The patient should be transported to the closest emergency department with imaging available. These patients, on arrival, will receive further blood tests and imaging in the likes of CT imaging of the brain. The ICP on scene should travel with this patient. The patient will likely require continual sedation to maintain the endotracheal tube, which is out of scope for practice for advanced care paramedics. Furthermore, the ICP may be required if there are complications with the endotracheal tube or the patient deteriorates and requires further pharmacological or skill management. Whilst urgent transport is required, it is vital that the patient is transported safely. This patient may be transported under road speed unless there is an indication to transport under priority 1 conditions. If the patient remains stable whilst intubated, a road speed transport is appropriate and safe. So there is no delay in offloading this patient and then receiving timely care. Always remember to pre-alert the hospital of your impending arrival with an IMIST handover and estimated time of arrival. The status epilepticus patient will require 2 crews on scene to manage them effectively. This means there is a need for clear leadership within the team. The team leader doesn't necessarily need to be the highest clinical level on scene. Each paramedic should have a clearly identified role, and this is to ensure no points of care are missed. These roles include team leader, airway, access and drugs, and runner. The use of a democratic leadership approach for this patient and for this team will be most effective. Despite the democratic approach, only 1 team leader is identified and reported to. Using a democratic approach, tasks are allocated to each member of the team. These tasks are then left to be completed by the team member independently. Once the task is completed, feedback is sought from the team leader, so no further tasks can be allocated. This ensures clear, closed-loop communication within the team and has been shown and linked to successful patient outcomes. That concludes this presentation this morning on the adult convulsive status epilepticus patient. Hopefully you've all had a refresher and been brought up to date on recent changes to best practice. Thank you for your attention, and always, please don't forget to record this for some CPD. Please reach out if you have any questions.